This UCSD TV program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest programs.
I am delighted to introduce Dr. Nev Jones, who will be talking about intervention engagement for transitional age youth. Nev is a mental health services researcher, consultant and trainer, and currently a postdoctoral fellow at Stanford University. She will soon be beginning a position as a research scientist for the Mental Health Services Oversight and Accountability Commission. So we're taking over. That's great. Dr. Jones's work is focused on systems approaches to community mental health transformation, as well as peer involvement and leadership in service development and evaluation. Previously, she directed the Lived Experience Research Network and Chicago Hearing Voices, and currently sits on the boards of the Community Health for Asian Americans in the Bay Area Hearing Voices Network. So we're delighted to have her, and I hope you enjoy your presentation. Thank you.
So what I am speaking about is actually a piece of the overall TAE project that we did in collaboration with Todd and Vicki, and this involved basically a literature review and an evaluation of kind of the level of evidence available for different types of interventions. My partner collaborator in this endeavor was Sarah McMenamin, who's an assistant professor here at UCSD. Okay, so I don't want to talk very much about myself, but I do want to say that I very much come at this from the perspective of a peer, as well as somebody who's been very, very involved in community mental health and in doing consultation directly in community mental health settings. So not as kind of the stereotypical removed academic researcher. Okay, so just to kind of set the stage and contextualize this sort of review and evidence review, we can, many people have commented on the fact that TAE-specific interventions are seriously under-researched. As Todd mentioned, there's really no comparison to child mental health services and adult mental health services in terms of how much research is available. And frequently what happens as a result is that practices and services in the TAE arena are based on sort of extrapolation from the adult and child evidence base. And we don't actually, in many cases, know if these interventions have the same effects on transition age youth. The sort of specific opportunities and challenges of the TAE period often go unaddressed. And examples of this would be, transitioning to independent living. Literally things like sort of learning how to cook, learning how to navigate social life sort of outside or beyond the family home, post-secondary education, developmentally specific milestones, right? So there's sort of socially and culturally normative things that we do as young adults that are not the same as older adults or mature adults. And some additional challenges in assessing the TAE evidence base include really uneven research funding, and there's, I think there's various things that contribute to that. There's a lot more money available for biomedical and pharmacological research, so that's one piece. There's also more money available for interventions that are initially tested in academic settings. So that might be an academic outpatient clinic, which is going to tend to be staffed by psychiatrists and clinical psychologists, not the people who run community mental health services. And research paradigms often don't fit some intervention areas. Probably the best example of this is naturalistic peer support. So a lot of arguments that we really cannot fairly randomize people to peer supports, that's not a fair test of real-world impact. And then there tends to be a focus on what I call pocket interventions rather than systems level interventions. So rather than looking at the entire kind of orientation or clinical ethos of a provider setting, we're looking at some little micro piece of that. So that could be a specific clinical approach like cognitive behavioral therapy, rather than looking at how all the clinicians across a team are interacting with each other and with their clients. And then assessment and review of values-driven interventions is really, really underdeveloped. And I would include a lot of peer supports in that category. So where, clients or family members are saying, this is really important to us versus this is really important to academic clinicians and researchers. Some additional challenges in identifying evidence-based practices. So I'm not sure of people's level of familiarity with this, but there's actually multiple evidence-based practice registries and algorithms or ways of deciding what is or isn't an evidence-based practice. So actually the phrase evidence-based practice doesn't have a singular meaning. We cannot talk about it's a evidence-based practice because we actually have registries and systems that are disagreeing on how particular interventions are categorized. And then the evidence base may or may not apply to particular settings or groups, right? So if we've developed an intervention that was tested in, rural Vermont with a, basically almost entirely white population, and then we move that intervention to California and try to implement it in an extremely ethnically diverse community, doesn't necessarily have an applicable evidence base. Then we have evidence-based practices by declaration. So the CMS, the Center for Medicaid Services, actually just in 2007 declared that peer specialists were evidence-based, that was their language, without any type of review process. And then again, this confuses providers, confuses folks working in community settings because this language gets tossed around a lot and it's not always clear where it's coming from or what it really means. An absence of evidence should not be seen as an intervention being non-evidence-based, right? So it may simply not have been evaluated yet or submitted to, for instance, SAMHSA evidence-based practice registry for review by SAMHSA. SAMHSA's review process is also extremely lengthy, so it can take in some cases years. And so you may already have systematic reviews or determinations by other systems saying this is evidence-based and SAMHSA doesn't yet list it that way. The funding of research and evaluation, again, is often very political. There's also a general lack of evidence regarding comparative effectiveness, and in many ways, PCORI, the Patient-Centered Outcomes Research Institute, was created in order to address this gap and really this major need in terms of services. So what comparative effectiveness means is we have this intervention that is oriented towards improving employment outcomes for consumers, and a different intervention, and we need to compare them to each other, not just compare an intervention to treatment as usual. And this becomes really, really important, I think, for community-based providers who are trying to decide between different interventions or different programs that kind of address the same need. Cost effectiveness is also, often really under-researched. There's a general lack of evidence on personalized intervention strategies, and so personalized medicine has become a big buzzword across virtually every other area of medicine, and sometimes it gets thrown around in the context of mental health services, but often not in a way that really has any sort of meaning or substance behind it. So it's very rare that clinicians are sort of administratively encouraged to look at an individual and think about what evidence-based or promising practices are the best fit for that person. A lot of the time they're encouraged to just apply a blanket intervention. And that, again, becomes really critical to evaluate in the context of very diverse communities, including LGBT youth as well as ethnic, racial, minority youth. So I advocate strongly for thinking critically about evidence-based practices, really thinking critically about all practices. We always need to be attentive to limitations to the generalizability of evidence-based practices, or again, really any practice or any service. So for instance, we want to always ask questions like, where was the intervention studied, with what population, who was excluded or included? The degree of mismatch between the samples in clinical trials and real-world clinical populations is notorious. At Stanford, I've been part of a team called CREAM, and we've been doing systematic reviews across every area of psychiatry as well as multiple non-psychiatric areas. And across our reviews, the rates of exclusion range from 70 to 90%. Huge gaps between who is actually being studied in the context of clinical trials and, again, these real-world clinical populations. Then we want to ask if there's other reasons to question generalizability. So maybe the median age of an adult mental health intervention was 40 or 45, or maybe even 50, right? Are there reasons to suspect that that intervention is going to have a different appeal or lack of appeal to youth, is going to affect them differently, is going to have less efficacy? Feasibility questions. So does the evidence-based practice actually fit a given service setting? So for example, if we're looking at cognitive behavioral therapy for psychosis, which was developed primarily in the UK in academic clinics led by highly, highly trained and skilled doctoral level clinical psychologists, is that necessarily the right intervention for a social worker who's doing primarily outreach, meeting with people in their homes, and simultaneously responsible for buying them groceries and making sure that their housing needs are met, et cetera, et cetera. And then finally, ecological validity. Does the evidence-based practice actually work the same way in a real-world community mental health setting? So finally, thinking a little bit about outcomes measurement as well, I think we always want to ask if the outcomes that were measured or that were used in the research are actually the outcomes of interest in an applied setting. An example would be if we want to improve educational outcomes in our community mental health setting, and we're turning to vocational interventions that have been shown to impact employment but not education, that's arguably an inappropriate intervention, or at least the evidence is not actually there. So it may be an evidence-based practice for one type of outcome. That doesn't mean that it is suddenly evidence-based for another outcome. We need to think about who's choosing the outcome. So again and again, and this is partly because academic settings tend to drive choices in terms of outcomes measurement, is that we see clinicians and academics selecting outcomes which are largely symptomatological in orientation or focus, rather than outcomes which we repeatedly see matter the most to peers and clients, which tend to be functional recovery, social engagement, as well as employment and work and school. And then there's trade-offs that we always need to consider between using an established evidence-based practice and maybe turning to something that's newer and more innovative and maybe will actually have more impact on the outcome we care about, but doesn't yet have that established evidence base. Okay, so really quickly going to go through why intervention and engagement matters. I think mostly I'm probably preaching to the choir here. This is a crucial developmental period. There's much higher risk of irreversible adverse events during the transitional period. Suicide is one of them. Adult criminal offenses is another. It's a unique opportunity also to make a difference for people when they are first coming in contact with the mental health system. Why the evidence base matters, again, really briefly, not all interventions are created equal, right? So we do want to use the interventions that are going to benefit our clients the most. A lack of evaluation or research can lead to a loss of a lot of critical information. And here I'm not just talking about academic research, but also internal evaluation and quality improvement efforts that allow us to optimize services, patient outcomes, to identify what's going wrong, and to identify subpopulations that are not being served. We need to be able to prove that interventions work or justify them often to policymakers as well as funders, and we can't lose sight of this. And also along similar lines, maintaining public support for services. And I think everybody's probably aware to some extent of the Little Hoover Commission report and of some criticisms of the MHSA. I suspect that everybody in this room also knows how incredibly important that MHSA funding is. We need to preserve it. We need to maintain public trust in how this money is spent and how it's affecting Californians. So our review, we had a limited amount of time, a relatively limited budget, so we couldn't do everything. It would be a gargantuan undertaking to try to review all the evidence for every possible type of intervention that would apply to transition-aged youth. So we selected 5 domains: multidisciplinary teams, vocational services, housing, peer-led interventions, and family services. We did not cover medication management, jail diversion or criminal justice system involvement, primary substance use interventions, primary prevention, or physical health and integrated care. That is not a judgment of a lack of importance of these areas. We just had to be more circumscribed about what we could cover. I'm not going to go into so the next slide is going to break down the evidence or the evidence-based categorizations that we came up with, which ranged from well-supported to insufficient. I'm not going to go into a lot of detail, but these slides will be posted, and I encourage people who are interested to come back and review them. Okay, so these are the exact criteria which we ended up using, which again did not necessarily map onto what SAMHSA has used or what other evidence-based registries have used. Okay, so first, multidisciplinary teams. So we kind of understood this as a family of interventions that utilize some sort of a multidisciplinary team, and this typically would include a case manager, somebody who is in charge of medication management, vocational rehab, sometimes therapy, sometimes group therapy, peer specialists, so there can be various components. Often is taking a holistic or sort of whatever it takes approach to serving clients. And we included in our review of this area process approaches like transition to independence process, wraparound systems of care. We included what we conceptualized as kind of clinical frameworks. So not necessarily just sort of individual cognitive behavioral therapy, but thinking about how cognitive behavioral therapy might be applied across a team and or in settings that vary in intensity. And in terms of just some concrete examples, specialty early intervention for psychosis services we included here, like PrEP in the Bay Area, full service partnerships, and assertive community treatment teams were all included. So as you might guess, this is, actually a well-supported area for adults, especially in terms of very, very rock-solid evidence-based practices like assertive community treatment. The evidence base for some of the newer team-based interventions, in part because they're newer, is less clear. So there's also, less evidence for lower intensity multidisciplinary teams. So sometimes I've heard people in the community refer this as assertive community treatment light, right, which could be considered low fidelity ACT, but also maybe it's ACT for people who aren't meeting the severity criteria for ACT. So just some brief considerations. In many cases, because our evaluation was of team-based, multi-component programs, the exact mechanisms and critical ingredients were unclear. The findings in terms of cost effectiveness are often much more mixed than the research on effectiveness. Long-term outcomes, disappointingly, are not nearly as strong as post-intervention outcomes. This is particularly true for early intervention in psychosis, where now the 10-year follow-up data is showing us a loss of almost all the gains that are initially achieved in terms of early intervention. So we definitely need to keep our eye on the long-term picture as well. The comparative effectiveness of different clinical frameworks is actually unclear because this is understudied. So for example, using a sort of motivational interviewing general strategy as part of a team versus a cognitive behavioral approach. We don't have a clear answer to that. There's a general lack of data on clinical approaches applied by frontline staff, right? So often bachelor's level or master's level social workers, therapists who don't have the same kind of ultra-specialized clinical training maybe as a clinical psychologist. And often program length is unclear because these are relatively expensive interventions. We don't really know how long they should go. Okay, so vocational services next. So these are, supports aimed at improving basically employment and or educational attainment. Examples of employment interventions, probably most people in the room are familiar with individual placement and support, which is kind of the evidence-based approach to employment. And then in terms of education, Trevor is going to be covering this a lot more in one of the breakout sessions, but there's no clear established evidence-based practice. Recent reviews of the evidence base for supported education have observed that the evidence we do have is often really out of date or of poor quality, and there's a major need for additional research and development here. So in terms of our review, we felt that employment was well supported for adults, promising for TAE. Education is really just emerging. Considerations, so here going back to some of my earlier comments on outcomes measurement, quality of employment outcomes is often not what's being measured. It's are people in some form of competitive employment, and we're not looking at are they really unhappy, are they ghettoized, are they low wage, are they working in what community practitioners refer to as the 3 Fs, food, filing, and filth. Educational attainment, we know, is particularly critical to long-term employment quality, as well as quality of life outcomes, long-term marriage or partnership status. So many outcomes that we really care about longitudinally are directly linked to educational attainment, and yet it's been deprioritized. Okay, housing. So as you saw on the initial slide regarding the survey, housing is a major issue in California. It's a major issue for TAE providers. Most of the interventions that have been developed, or at least with the strongest evidence base, are specifically targeting homeless populations or those at risk of homelessness. So this is kind of a caveat to keep in mind. And then there's many examples of supported housing, scatter site using vouchers, dedicated cluster site supported housing, group homes, short-term transitional housing, SROs, or board and care facilities. And particularly looking at sort of, again, the evidence-based leader in terms of supported housing, which is the Pathways Housing First model, we determined that it's supported for adults, emerging for TAE, and this is mostly because studies have not been carried out within the TAE population yet, or not many studies. And even in terms of adults, we're not necessarily, most of the evidence has focused on, again, this sort of the homeless population, not necessarily folks with other types of housing-related needs. Here in particular, youth-specific considerations have been really understudied. So what sort of socially normative housing looks like for young people versus mature adults or older adults. So the obvious example is that a lot of young people live with roommates. They crash on the floor of an expensive apartment in San Francisco or LA. So it's not necessarily clear that we should be measuring good outcomes for this population in exactly the same way. way. And then, interestingly, the pros and cons of remaining in a family home are understudied. And again, this is increasingly the norm for a large percentage of young adults in this country. Housing is increasingly expensive and out of reach, so people stay at home. Is that good? Is that bad? How do we sort of take stock of that? Peer-led interventions, so again, a family of interventions and supports that are led or designed by peers. We didn't really specifically break out peer specialists versus peer-led programs in the review, and I think there are different conceptual issues at play here, which we'll cover a little bit more in one of the breakout sessions later this afternoon. But basically, peer specialists, arguably, what we really need to, all that we needed to establish, which has been established, is that when performing the same duties as like a case manager or other frontline staff, they do just as well, and that's been established. What hasn't been shown necessarily is an improvement of peer specialists over regular case managers. Then a different case can be made there for greater cost effectiveness of peers because they're paid less, which is a political problem unto itself. So some examples include peer support groups, wellness recovery action plan groups, peer-run crisis respites, peer-run TAE activities like running a music group or doing some sort of outreach or creative activity, et cetera. So the level of evidence for adults we decided was ambiguous. The reason why is actually a meta-analysis, a kind of pooling of data from multiple peer-led intervention studies actually came to the conclusion that they were not more effective than comparators. There was a competing meta-analysis that came out within the same time frame that came to the opposite conclusion. So there's competing evidence, and we didn't have the time to dig into the details of every little study and sort of figure out what's really going on. It's clear that for specific peer interventions like RAP, the evidence base is very strong. So it gets much more problematic when you're trying to generalize across a very large and diverse group of interventions and programs. I also want to point out that there's an abundance of unstudied, small, but seemingly very innovative and promising peer-run programs, and that is especially true throughout the state of California. Finally, family services. So our definition, again, was a family of interventions that are focused on family support, outreach, or involvement. Again, a very diverse kind of group of different types of programs and interventions, and with varying levels of evidence for the specific interventions. So examples that folks in the audience may be very familiar with are multifamily groups or multifamily psychoeducational groups, and then policies that encourage and facilitate family involvement in TAE services. So for adults, we determined that the evidence, or that these programs are generally well supported, and they're kind of drawing on not only support for particular interventions, but also the overall empirical support for the fact that family involvement is really critical to improving youth and client outcomes. TAE, again, promising, it's well supported for multifamily groups, but there just hasn't been as much dedicated research. So summary and challenges. So as I've described, there's kind of a very uneven evidence base. We have more evidence in some areas by far than for others. That doesn't mean that they're necessarily less valuable. There's a number of kind of remaining and very important questions and challenges. So one is how to deconstruct these negative or neutral studies of peer support. Is this really a criticism of or a critique of peer support in terms of its full potential, or the way that specific programs are being implemented, or lack of quality within the development of the programs that aren't working, because then we see some programs that obviously are. And then what makes for effective or ineffective peer-led programs? I think everybody in this room can probably agree that it's not enough to just have your own lived experience to be able to work very, very effectively with other peers and clients. So how do we go beyond that? How can we develop a strong evidence base and effective programs for increasing educational achievement? This is just a major problem area facing the TAE population. Again, really glad that Dr. Manthey is here to address that. How can we address chronic housing shortages, particularly pressing question in the state of California, and especially in areas where housing costs are spiraling out of control? Then this question of impact being sustained or not sustained over the long term. So this, I think, just quite distressing evidence on the loss of gains from early intervention programs that don't pan out in terms of long-term improvement. Okay, so getting local, so just a few concluding comments. So I think the MHSA really provides amazing opportunities for developing and sustaining innovative and effective TAE services, and having come from the state of Illinois prior to moving out to California, it is a night and day difference. It is, astounding and amazing to me what can be done in the state of California. None of these resources or possibilities are available in Illinois. There's tremendous innovation across the state. And there's the potential, therefore, because we have the MHSA, because we have funding for evaluation in many cases, and because we have, support for innovation, the opportunity to establish an evidence base with truly national and international implications. I think there's a lot of potential for systems and agency level policy and transformation, as well as individual interventions. And then there's high levels of peer and family leadership throughout the state, certainly in terms of how the MHSOAC operates, less so, as I'll say in the next slide, in terms of evaluation and research. And there's a much stronger emphasis actually on campus mental health than we find in most states. Limitations and challenges. So as we saw, there's sort of underdeveloped evaluation and QI in many counties and programs, and also just a lot of variability. Some counties who are doing amazing, QI work, and some who are doing, almost nothing. Uneven use of established evidence-based practices, often without fidelity checks. Interestingly, we asked an open-ended question on the survey about evidence-based practices, and some of the sort of self-filled in responses were definitely not in the sort of clearly established evidence-based category. So people don't necessarily even know, I think, what is or isn't, and as I have explained earlier, that's kind of an open question, and it's not surprising that it's so confusing. The adaptation of evidence-based practices to youth, as well as to ethnically, racially diverse communities. The trans community, I think, as well, is a big community in California, and really in need of dedicated kind of attention. And there's, as we know, silos and fragmentation across systems and also across counties, which is, I think, a particularly pressing issue in California. And then finally, there are these sort of structural and non-mental health systems barriers, such as a lack of affordable housing. Okay. So moving forward, I'm sort of, repeating some of what Todd already said in the initial presentation, but I think there's a lot of concrete opportunities here to partner with researchers as well as government. So of course, I say that as a soon-to-be oversight and accountability research staff member, and to track outcomes, to address and improve local evaluation, QI, and sort of participate in the collection of common statewide metrics, which is a lot of what the OAC is trying to pursue, to address silos and increase coordination across systems and counties. And so again, not just across county lines, but also, for instance, between schools in the mental health system, between post-secondary education in the mental health system, figuring out how to replicate successful programs in other counties. So actually, when I was doing this literature review, I found some just really amazing stuff going on in California, and then you look at a different county and they seemingly have no awareness that that's happening one county over, or that there are these, amazing models that they could build on rather than reinventing the wheel. And then focusing our energy on unmet needs and priority populations. And although we didn't cover every area of relevance, criminal justice involvement being a huge one, I think we definitely identified areas in which there's a huge need to do more evaluation and research. Okay, so sorry I talked longer than I intended, which almost always happens, but I hope you guys have questions. Okay, so the first question is just about research regarding the loss of long-term gains sustained for early intervention in psychosis. I'm not sure exactly how to do this, but if there's a way that we can post the full text of articles on the TQI website, I'm very happy to actually just post these articles so that people can look at them. Example of understudied innovative small TAE services which are producing milestones, models working in counties. So I think just effective small TAE services. Examples are both Project Return and Peers, which are peer-run organizations. One in the Bay Area, one in LA, are doing, I think, a lot of amazing work focused on the TAE population, led by the TAE population. Much less going on in those programs in the way of evaluation. In San Jose and Santa Clara County, some really innovative work running residential facilities. So there's a lot going on, and I do, as Todd said, like more sharing of that would be amazing. Let's see, potential systems change at agency level. So that's a huge question. Whoever asked the potential systems change at the agency level, please come and talk to me. A lot of the work I do, actually consulting outside of the state of California, is looking at this issue, but it's huge and complicated. I do have a lot of ideas. We're almost out. We don't have evidence that the inclusion of a peer specialist can increase the effectiveness of multidisciplinary teams yet. There's some emerging evidence on assertive community treatment. There is absolutely nothing in terms of early intervention in psychosis. In fact, there's no research on peers in early intervention in psychosis, period. And the presentation will be posted. And the details of the evidence-based practice review criteria are the exact criteria we used are in this PowerPoint, and also I'm guessing that the full literature review and review can be posted on the website, so there's a lot more detail there. And I don't think there's a most authoritative source for evidence-based practices out there. And in part, it depends on how that claim to be an evidence-based practice is being used. So the implications of being listed in SAMHSA's registry are different from, for example, the state of California out of the University of California runs a new evidence-based practice registry that is not going to have the same clout as SAMHSA and has different criteria. But yeah, Are psychotropic meds really evidence-based for TAE? I mean, this is a huge issue, and some of you probably are aware of the widespread use of antipsychotics among youth in California in the foster care system. This is a major legal issue. There's essentially no evidence base at all that antipsychotics should be used on youth without any psychotic disorder as sort of a form of behavioral control. And there's lawsuits in process and already being filed. And I think their academic psychiatrists, most of them would be equally sort of critical of what's happening. And that, opens up a bigger issue about the use of medications among youth. Sorry. Ari, the meta-analyses, please summarize main findings, competing results on peer services. Yeah, right, again, it would be better to post these so that you can see exactly what people did. And of course, there's different inclusion-exclusion criteria often being used. In some cases, a focus on just a particular type of peer-led intervention. Often in these certainly in these meta-analyses, qualitative evidence on, the effects of naturalistic programs is just completely excluded. So really to sort through all of that, takes a lot of energy and a lot of critical thinking, and, part of that probably comes down to where you stand in terms of what evidence you think matters and how much you also think that sort of, peer involvement and peer leadership is, also a values-based or rights-based kind of intervention type. So I think that I blitzed through those. Please come up and talk to me during the breaks and we can discuss these issues more, but thank you all so much.